Hello, my name is Natalie Vaughn, and I am a hand surgeon with Virginia Tech Carilion School of Medicine in Roanoke, Virginia. Today we're going to be discussing congenital upper extremity hand differences. I have no conflicts to disclose. This is a pretty extensive topic, so I'm going to try to hit the high yield points for each diagnosis, though each topic would probably merit an individual lecture in its own right. We're going to start out by discussing embryology, and then we'll go over the two major classification systems. Finally, we will perform an overview of many common diagnoses within congenital hand differences. Upper extremity differences make up about 10% of congenital anomalies that affect newborns, second only to congenital heart disease. Typically, these are spontaneous or are inherited and rarely are related to teratogens as well. In terms of the development of the limb bud typically appears around 26 days after fertilization and then rapidly grows over the course of the next several weeks. By day 33, the hand paddle has appeared and digits develop on the paddle by day 41. By day 54, all fingers have separated. And typically by 8 weeks gestation, all limb structures are present, so most congenital anomalies will develop between weeks 4 and 8 of growth. Limb bud growth starts from growth of the mesoderm into the ectoderm, and the cells from the lateral plate mesoderm become the bone, the cartilage, and the tendon, whereas the somatic mesoderm forms the muscular, nervous, and vascular elements of the limb. The limb bud is divided into 4 zones of growth corresponding to different proximal to distal anatomic regions. The axes of the limb are controlled by different signaling centers in terms of their growth: anterior to posterior, proximal to distal, and dorsal to ventral. The proximal to distal growth is guided by the apical ectodermal ridge with P6E, wingless type, and fibroblast growth factors. The anterior to posterior type of growth, which in the hand refers more to radial to ulnar, is dictated by the zone of polarizing activity and the sonic hedgehog protein. Dorsal to ventral is largely guided by the wingless type with LMX1 pathway. The apical ectodermal ridge responds to fibroblast growth factors, and it promotes proximal to distal limb development and then allows for interdigital necrosis to develop between the individual digits. An anomaly in the apical ectodermal ridge will lead to a transverse deficiency, so insufficient proximal to distal growth. The shoulder develops first before the elbow, and then the elbow before the wrist. Failure of the FGF factors after limb development will also alter the normal programmed apoptosis that occurs that will allow the digits to separate, and so that can cause syndactyly to occur. The zone of polarizing activity produces sonic hedgehog protein, and it's responsible for the radial to ulnar or anterior to posterior development and expansion of limb width. The zone of polarizing activity is present within the posterior margin of the limb bud, and sonic hedgehog protein induces ulnar formation, and this is both timing dependent with the index and long fingers exposed for the shortest amount of time and the small finger exposed for the longest amount of time. Without this pathway, there is mirror hand or failure of differentiation between the radial and the ulnar sides of the hand. This is a dose-dependent problem and can lead to variable numbers of fingers and different phenotypes of mirror hand if errors in this pathway occur. The wingless type pathway is responsible for dorsal to ventral signaling with the transcription factor LMX1 induction. This causes the mesoderm to adopt dorsal characteristics, and so if there are abnormalities in this pathway, there's abnormal nail and pulp arrangements, and the best example of this is nail patella syndrome with loss of LMX1. Limb development is also affected by mutations for different signaling proteins, receptors, and transcription factors. HOX and TBOX genes code for transcription factors that are important for limb formation, and Abnormalities in these can cause different types of Symbrachydactyly or other associated extremity syndromes. In these situations, genetic counseling is recommended. Different examples of these might include cardiac defects and radial deficiency in the setting of Holt-Oram syndrome, which is an autosomal dominant with variable phenotypic expression syndrome. There have been several classification systems that have been proposed, including that by Swanson in 1976, which was published in the Journal of Hand Surgery at that time, that separated abnormalities by failure of formation, differentiation, duplication, overgrowth, undergrowth, etc. Now the more accepted standard is the Oberg, Mansky, and Tonkin classification, as demonstrated here. And the OMT classification separates anomalies by malformation, so abnormal formation of a body part, deformation or alteration of a body part after its normal formation, such as in constricted band syndrome, and dysplasia with abnormalities in the size, the shape, or the organization of the cells, such as in macrodactyly. And then syndromes are a final class. There are multiple congenital differences that we'll discuss in more detail today. The most common of these is syndactyly, as well as polydactyly, camptodactyly, and various types of amputations. It's important to note that many times congenital hand differences are accompanied by psychosocial implications for the family and for the patients. And parents may feel prolonged grief or guilt. This is normal and it's expected in this scenario. It's critical to establish priorities early. Function is much more important than form in these situations. And so recognizing with the parents and with the patients the goals of care. And internet and support groups may be very helpful for patients and their families to feel connected as an additional resource to other patients with these conditions. So we will start by talking about radial longitudinal deficiencies, and this represents a spectrum of abnormalities varying in severity from mild thumb hypoplasia to complete absence of the radius. The radial longitudinal deficiency is the more common type of congenital longitudinal deficiency, and typically it is related to mutations in sonic hedgehog or FGF signaling pathways. It's an incidence of 0.5 per 10,000 live births, and about half of these deficiencies are type N or 0 with more mild symptoms involving the thumb and the carpus primarily. Here you can see the James modification of the Bain classification system. Often these radial longitudinal deficiencies are seen in syndromes, and so a workup of other potentially affected organ systems can be not only part of a complete assessment of the patient, but can also be life-saving. And so these should include a renal ultrasound, an echocardiogram, spine radiographs, and a complete blood count. The treatment of radial longitudinal deficiencies typically varies depending upon patient age as well as the severity of the deformity. Types 0 or 1 may only need some stretching or splinting. And splinting is typically initiated around 3 months of age. With more severe longitudinal deformities, there's hypoplasia of the radius, and often soft tissue releases and tendon transfers can be helpful, and sometimes centralization of the carpus to the ulna can be performed to improve stability of the wrist as well. In severe radial longitudinal deficiencies, there is absence of all of the radial structures, including the radial wrist extensors and the thumb extensors. The superficial radial nerve may be absent, whereas the median nerve is often present or almost always present, and is typically, it may even be the most radial structure volarly in the wrist. The radial artery is typically absent. Centralization of the wrist, as mentioned before, can help to stabilize the carpus on the forearm, but it is contraindicated if the patient has an elbow extension contracture, as often radial deviation of the hand is necessary for patients in these scenarios in order to reach the hand to the face. Centralization often improves the appearance of the extremity, but may not improve the function dramatically and can increase the stiffness of the wrist and does have a tendency to recur. In centralization, the wrist capsule is incised to expose the ulnocarpal joint in the distal ulna, and the carpus is reduced onto the distal ulna and pinned in place. Often this requires release of tight radial structures, and many times preoperative soft tissue distraction is used for staged control of the tight radial structures. The ECU tendon is also advanced in this procedure to improve tension, as it may be the only functional wrist extensor. Rarely, ulnar lengthening is also indicated for these patients, and thumb hypoplasia, if present, will also be addressed at a later time after the centralization is performed. Ulnar longitudinal deficiency, on the other hand, is less common than radial deficiency and tends to have more of a sporadic origin. It's more commonly unilateral. Typically, the elbow is abnormal and may be fused. And in these scenarios, most hands are missing digits, may have syndactyly, and may still also have some thumb deformities as well. In classification of this deformity, type 0 involves the carpus or the hand only. Type 1 is an undersized ulna with bone growth centers both present. Type 2 is an absent distal ulna. Type 3 is an absent ulna entirely. And type 5 involves total absence of the ulna and synostosis of the radiohumeral joint. Surgery is indicated in these patients to improve hand function. External rotation osteotomy of the humerus may improve the position of the hand relative to the torso, as many of these patients have a hand which is essentially positioned backwards relative to their body. Syndactyly releases may also be required, and thumb reconstruction is recommended in some form if hypoplastic are absent. Many times patients with ulnar longitudinal deficiency actually adapt quite well despite their deformities, and while one bone forum is an option to improve stability, it comes at the cost of forum rotation, which may be an unacceptable trade-off for otherwise functional children. Ulnar Dimelia, a type of mirror hand, occurs after failure of the zone of polarizing activity, which recall is the anterior to posterior differentiation, to adequately express sonic Hedgehog protein. Ulnar Dimelia is a type 1 mirror hand in which there are multiple fingers and 2 ulnas present. There are also some intermediate forms that occur with multiple fingers, 2 ulnas, 1 radius, as well as multiple fingers, 1 ulna, and 1 radius. Typically speaking, these patients have poor forearm rotation, and treatment typically involves reduction of the digits with ray resection and policization of the thumb using one of the additional digits. Next, we'll talk about thumb hypoplasia, and this can occur independently or as in the context of radial hypoplasia or radial longitudinal deficiency. It's bilateral in about 20 to 60% of patients. This treatment is heavily dependent upon the presence or absence of a stable carpometacarpal joint. There are 5 types of thumb hypoplasia, ranging from mild to complete absence of the thumb. Type 1 thumb hypoplasia is mild with a slight decrease in the thumb size and diminutive bones, but normal thenar musculature, and so this does not require surgical treatment. For type 2, with abnormal musculature and narrowing of the web space, the surgical treatment involves deepening of the web space as well as opponentsplasty. The patient may also have an unstable MCP or ulnar collateral ligament, and reconstruction is indicated if so, and MCP fusion can also be considered to improve the stability of the MCP joint. Web space deepening can be performed with local soft tissue rearrangement flaps, and opponentsplasty options include the ring finger FDS, as well as the abductor digiti minimi, or a so-called Huber transfer. For type 3, the patient also has abnormal extrinsic thenar or extrinsic muscles to the thumb and possible bony deficiency as well. In patients with a 3A thumb, there is a stable CMC joint. In these patients, reconstructive options are still a possibility, but in a 3B, where the CMC joint is unstable, policization is indicated. Policization requires very careful surgical technique. The hypoplastic thumb is deleted and the index finger is used to replace this. The radial digital artery to the thumb is ligated, and then the index metacarpal is deleted from its physis to its base with effective shortening of that index finger. It's then transferred to the carpus and pinned in place. The abductor pollicis brevis is reconstructed using the first dorsal interosseous muscle, and the adductor pollicis is reconstructed using the first palmar interosseous muscle. Early pollicization is often more favorable for neuroplasticity. Outcomes often are dependent upon the preoperative status of the index finger. And there are many complications associated with this procedure, including vascular compromise, scarring, stiffness, and limited motion. Next, we'll talk about polydactyly, or the presence of additional digits. This is often related to the Hox gene. Sometimes the sonic hedgehog pathway is also abnormal, leading to excessive growth in the radial to ulnar plane. Polydactyly can be either preaxial on the radial side or postaxial on the ulnar side of the digit, and there can also be central polydactyly. Typically, postaxial polydactyly is inherited in an autosomal dominant fashion and is more common in those of African descent. Preaxial polydactyly is more common in Caucasian patients and is fairly frequent, 1 in 140 to 1 in 300 live births. Preaxial polydactyly, as mentioned, is more common in Caucasian patients and is described using the Wassel-Flatt classification, as describes the type of duplication and location. The type 4 is the most common level of duplication, and this involves duplication of the distal and proximal phalanges in a single metacarpal. Type 7 is the most complex and requires at least one triphalangeal thumb to be present. Treatment is pursued after 12 to 24 months of age. In types 1 and 2, the duplicated distal phalanx is split centrally and then combined. This does typically lead to a split nail and a somewhat broad residual thumb. For Wassel 3, with a bifid proximal phalanx and 2 distal phalanges, the smaller of the 2 thumbs is deleted. It's important to note that both thumbs will be smaller or hypoplastic compared to the normal or contralateral side. For Wassel 4, the most common, the ulnar thumb is typically preserved for maintenance of the ulnar collateral ligament, and then the digit is centered on the metacarpal and is pinned in place. The collateral ligaments, flexors, and extensors are all preserved from the deleted thumb and are repositioned to a more central location on the residual digit. Type 7 is a triphalangeal thumb, and this is often associated with other congenital abnormalities such as Fanconi's anemia or Holt-Oram syndrome. Postaxial polydactyly, on the other hand, is typically an autosomal dominant type of inheritance with variable penetrance, and it can be bilateral. It's much more common in those of African descent, 1 in 143 versus 1 in 1,339 Caucasians. In Caucasians, postaxial polydactyly may be related to a syndrome such as chondroectodermal dysplasia or Ellis-Van-Creveld syndrome. Type A involves a well-developed digit, and type B is a pedunculated or diminutive digit. With type A, operative separation is typically recommended, and the ulnar collateral ligament and abductor digiti quinti are transferred to the adjacent digit for additional stability. Type B can be ligated with a suture or a vessel clip, though the complication associated with this involves a small nubbin or potentially a neuroma formation and may be appropriate for surgical excision with local anesthetic. Next, we'll talk about cleft hand or central deficiency. This is a longitudinal deficiency that affects the central digits. Typically, cleft hand is an autosomal dominant inheritance pattern and may be associated with a syndrome such as split hand, split foot, or EEC syndrome. It may be unilateral or bilateral. It is about 5 times more common in males. These patients will often have some form of syndactyly, as well as duplications adjacent to the cleft and phalangeal anomalies within the cleft. X-rays should always be obtained to evaluate osseous anatomy, as often there are transversely oriented phalanges contributing to the deformity and promotion of the cleft. The most commonly used classification currently described by Manksi and Halakis is based on the first web space, and the authors noted the relationship between increasing tightness of the first web space with increasing severity of the cleft hand. This classification is useful in surgical decision-making because it emphasizes that the main functional challenge with cleft hand is based upon that tightness of the first web space, not necessarily from the presence of the cleft. Surgery is indicated in these patients to both improve the appearance and the function of the hand, though oftentimes function is fairly well preserved in these patients. Surgery is indicated for progressive deformity and insufficient first web space, deformity of the cleft, and absent thumb. And the surgical treatment here involves removal of transversely oriented bones as well as syndactyly release with a deepening of the first web space and closure of the cleft. Care is taken to preserve the web space commissure in the cleft with the flap while still closing down the borders that are present. Dorsal Dimelia results from errors in the dorsal to ventral axis, again from the wingless type pathway from LMX1. One such example of this is nail patella syndrome, in which the patients have hypoplastic nails, patellar deformity and instability, renal defects, and conical iliac horns. And here you can see the hypoplastic nails on the dorsum of the hand from inadequate. Syndactyly refers to fusion of adjacent digits and can involve soft tissue and/or bony elements. It occurs from failure of normal digital separation and may be related to the apical ectodermal ridge pathways from programmed apoptosis of the web space cells. It affects 1 in 2,000 live births and is 10 times more common in Caucasians and twice as common in males. The most common location involves the long finger to ring finger, followed by ring finger to small, and it is least frequently seen in the first web space. It is often bilateral, and many patients do have a family history of syndactyly as well. Anatomically, there may be abnormalities of the nails, the digital neurovascular bundles, the phalanges, and the tendon systems. Typically, the Cleland's and Grayson's ligament complexes are thickened and coalesced, and there is extensive and thick web space volar fascia present. Syndactyly is considered complete if the web space extends to include the fingertip, and incomplete if the web space occurs between the normal commissure and the fingertips. Simple syndactyly refers only to skin or soft tissue connections, typically with normal joints and independent tendon systems. The ligaments are often normal in these patients, and there may be duplicated sheaths, tendons, nerves, and vessels present. Complex syndactyly has skeletal abnormalities associated with it, most commonly a side-to-side fusion of the distal phalangeal tuft. Complex complicated syndactyly are those with accessory phalanges interposed in the abnormal web space as well. In preoperative planning, it's important to consider which structures are involved, the extent, the nail involvement, and the presence of differential motion. Radiographs should always be obtained, as they may reveal a concealed extra digit or syn polydactyly. Ultrasound or MRI can also be helpful in these cases to determine the anatomy of the flexor tendon and vascular networks. Surgical management is often recommended, as syndactyly can have both cosmetic and functional and developmental impacts. It hampers grasp and pinch, and it inhibits digital motion and abduction, which effectively narrows the hand. It can also cause flexion contracture of the PIP of the longer digit, which progresses as the hand grows. Contraindications to surgery would include mild incomplete syndactyly without any functional impairment, or complex syndactylies that would risk further functional impairment with attempted separation of the digit. For example, if separation of the parts would not produce reliably independent, stable, mobile digits. Surgical timing in terms of the goal of separation of the digits is typically by school age, though you want to wait until at least 9 to 18 months before performing the first separation. If multiple digits are involved, staged procedures are typically considered to avoid vascular insult to any one digit. Complications of syndactyly surgery include vascular compromise, infection, wound dehiscence, loss of graft, and most notably web creep with scar contracture over time. In simple syndactyly release, you must reconstruct the intradigital commissure with local soft tissue rearrangement to cover the web space gaps that are made from separation of the digits. Often speaking, syndactyly release must be supplemented with skin grafting obtained from the inguinal crease, the popliteal crease, the antecubital fossa, or the hypothenar area of the hand. Full thickness skin grafts are preferred to lessen the secondary contracture that will occur. Often a rectangular proximally based dorsal flap is used for the reconstruction of the web space commissure. In separating the digits, the parenchyma needs to be preserved, and the neurovascular bundle should always be identified proximally and volarly before dissection. The proximal limit of separation of is the bifurcation of the digital artery. In very rare situations, digital artery ligation can be performed to increase the depth of the planned web space if there's adequate blood supply from the other digital artery. You could also consider a vein graft in these scenarios. In first web space flaps, often Z-plasty or even pedicled flaps can be considered if they're severe in nature. Complex syndactyly involves the bony structures as well, and often is associated with a syndrome, for example, Apert syndrome or Poland syndrome. In Apert syndrome, there's a combination of bicoronal craniosynostosis and midfacial hypoplasia with severe complex syndactyly of the hands and feet. That results from a mutation of FGF type 2 on chromosome 10q. There are severe complex syndactylies present in these patients, possibly with fusion of the distal phalanges causing a bunched or rosebud appearance with a hollow in the palm. And often speaking, there's an inverse relationship between the severity of the hand deformities and that of the craniofacial deformities. For these patients, staged digital release is performed, typically beginning with the border digits. Symbrachydactyly, or short-webbed digits, is either sporadic or is also associated with syndromes, for example, Poland syndrome. In this situation, there's hypoplasia of the upper limb due to inadequate subclavian blood flow. And Symbrachydactyly with short-webbed digits is a potential feature. Surgical treatment typically involves separation of the digits as described previously. Camptodactyly is another relatively common congenital difference, and this involves a flexion contracture of the PIP joint, typically of the small finger. It's fairly common, about 1% of the population has some form of camptodactyly present. The joint has fully developed, but there's significant contracture present at birth, typically due to some form of extrinsic etiology. As this can interfere with grasp, surgical treatment is often recommended. Splinting can be performed either nocturnally or in severe cases during the daytime as well. Most children have a plateau in improvement with splinting around age 2. Surgical algorithms involve a volar Z-plasty to release the pterygium at the PIP joint with FDS release at the PIP joint versus transfer of the FDS to the lateral bands. You can also consider dividing the check rein ligaments as well for improved extension of the PIP joint. K-wire pinning of the PIP joint can be employed to maintain the finger in maximal extension. Clinodactyly involves angulation of the digit in the radial-ulnar plane greater than 10 degrees. It is common to see this in the small finger. It's more common in males and can have an autosomal dominant inheritance pattern. This can arise either due to a longitudinal epiphyseal bracket or an abnormal shape of the phalanx or both. The IP joint is deviated away from the normal axis and asymmetric longitudinal growth occurs. In the situation of a longitudinal epiphyseal bracket, this can even form a C shape that unites the proximal and distal growth centers and can further deviate the axis. Surgery is typically indicated for functional limitations, but not for cosmesis purposes. Involvement of the radial digits or the thumb is more likely to cause problems with pinch grasp. Splinting is not typically helpful in these patients, and to treat the patient surgically, you must address the underlying deficiency either in the bracket or in the bone itself. In patients in whom a bracket is identified, resection of the longitudinal physis with preservation of the growth plate is indicated, and that can be performed between 3 to 4 months of age to realign the axis appropriately. If there is an abnormal shape of the phalanx, so a trapezoidal or a so-called delta phalanx, these patients need to be treated after skeletal maturity with an osteotomy. While a closing wedge osteotomy is technically simpler, it can lead to additional shortening of an already shortened digit. An opening wedge osteotomy with grafting may be preferred in these patients. In amniotic band syndrome, there is partial or complete constriction of a limb. This is most common around the upper extremity and is typically present distal to the wrist. It is postulated that the limb gets entrapped within the ruptures of the amniotic wall. It can cause distal edema or even amputation after compromise of limb viability. The constriction can also cause otherwise normal digits to fuse together, producing a syndactyly, sometimes interrupted with a more proximal sinus. Of note, the proximal structures are normal in these cases. Classification system involves the complexity of the rings, including the possibility of acrosyndactyly. There have been reports of in utero fetoscopic band release of the lower limb, but that scenario is typically limited to loss of circulation that would otherwise result in loss of the limb if left alone. And there is a high risk of spontaneous abortion after this type of procedure. To treat amniotic band syndrome, typically the goal is to improve both the function and the appearance of the extremity. The constriction ring is incised, and often Z-plasty or W-plasty is performed. There have been reports of complete circumferential surgery, though often this is performed in a staged manner. Syndactyly release is performed, typically with early release of the distal connection to untether the growth of the digits and to prevent contracture from forming. Digital transfer can also be considered if it may improve function. Macrodactyly refers to disproportionately large digits, either present at birth or which develop within the first few years of life. Typically, the onset is sporadic. Most commonly, it's an isolated anomaly associated with lipofibromatosis of a more proximal nerve, though there are associations with neurofibromatosis as well. Classification is based upon the etiology of the macrodactyly. Type 1 are those that are associated with lipofibromatosis, and these can be static or progressive. Multiple digits may be affected, and divergent deviation of the digits is often seen. The digits tend to stiffen with time as the skeleton grows as well. There may be fatty infiltration seen around the median or ulnar nerves that are involved, even to the point of causing compressive neuropathies. And there may be associated syndactyly in these patients. Type 2 macrodactyly involves neurofibromatosis. Type 3 is hyperostotic with nodular enlargement of the digit and severe limitations in motion. And finally, type 4 involves overall gigantism that may impact the entire limb or the entire body part as well. Treatment is indicated in macrodactyly due both to the social implications of this congenital difference as well as limitations in function and grasp. The treatment is challenging due to the progressive nature of the problem. This can prevent complete correction, and multiple surgeries may be necessary. Procedures can be performed to limit growth, to reduce the digit size, to correct the angular deformity that is often present, or in some situations, amputation may be appropriate. Epiphysiodesis can be performed when the digit is at the same size as that of the same-sex parent. Angular deformity can be corrected with closing wedge osteotomies. Debulking procedures remove excess subcutaneous fat and skin, and the bone can also be narrowed during those procedures with a burr. Sometimes the middle phalanx may also be completely deleted to shorten the digit. If the macrodactyly involves a single digit and there is progressive uncontrollable growth, amputation may be considered. Border digits are well treated with ray amputation, whereas central digits can be treated with transmetacarpal amputation and transfer of the adjacent digit. That completes this review of congenital hand differences. Here are the references that were utilized in preparation of this talk. Special thank you to Dr. Apical and Dr. Bravo for some of the cases and content. Thank you very much, and I hope that you learned something during this lecture.